Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Healthcare has a problem that no EHR can solve, no AI deployment can fix, and no digital front door can open. The problem is this: we've spent the last 50 plus years building one of the most complex organizational systems in human history. And then we keep asking it to do something that it was never designed to do. We ask it to transform while running on a model built for a completely different era. That tension between what technology now makes possible and what organizations can actually absorb is what this season is all about. Welcome back to the Eye of the Needle. I'm Pam Arlotto. And if you're new here, this podcast is where we talk about change in healthcare, the way leaders actually experience it, not the press release version, not the hype, the real version. We took a break since our last episode. We've spent 3 months doing research and in-depth consulting work with a number of clients. The time gave us an opportunity to reflect. Last year, we talked a lot about innovation, the innovators, the solutions, the technologies trying to thread the needle into a resistant healthcare system. This year, I want to talk about the healthcare system itself. But let's look at what's changed in the market since our last episode. Agentic AI moved from theory to reality. Ambient AI went from pilots to production across hundreds of health systems. Digital workers, actual AI agents that execute workflow and complete tasks, began appearing within care delivery organizations. And on the other side of the ledger, workforce shortages persisted, margins stayed under pressure, governance fell further behind, and operating models that drive most healthcare organizations, the actual organization structures, processes, incentives, and decision-making approaches, remained almost entirely unchanged. As I said earlier, the gap between what technology can do and what the organizations can actually absorb, that gap is not closing. In fact, it's getting even wider. That is the challenge I've spent over 40 years watching, and I want to be direct with you. We are at an inflection point in our healthcare industry, unlike any previous wave of technology deployment. Not because the technology is more powerful, even though it is. The cost of limited organizational change is catching up with us, and it's never been higher. The leaders who figure this out in the next 3 to 5 years will define what high-value healthcare looks like for the next few decades. The ones who don't will be managing a slow decline, but they'll have better dashboards. So before we go further, I want to revisit the purpose of this podcast and why I named it The Eye of the Needle. When I launched this show last year, the premise was straightforward. There are thousands of innovators out there, startups, entrepreneurs, technologists, working on real solutions to real problems in healthcare. And there are thousands of health systems, physician groups, payers, and employers dealing with those exact problems. Yet they often remain unsolved. The tragedy isn't that the solutions don't exist. The tragedy is getting the organizations with the problems together with those building the solutions, getting the right innovation to the right organization at the right moment. It was nearly impossible. The passage is too narrow, the eye of the needle. So last year, we brought innovators onto this show. We told their stories, we explored what they were building and why, and something became very clear to me. Not right away, but episode by episode. The needle is getting narrower because of the organization on the other side trying to absorb that innovation. You can have the most elegant digital health solution in the world. You can have a proven return on investment, a seamless implementation, a champion in the C-suite, and it will get stuck in procurement, in governance, in competing priorities, in a culture that rewards optimization of the old business model over transformation to a new approach. So this season, I made a decision. If the real constraint is the organizational model itself, if that's what's making the needle so hard to thread, then that's what we need to talk about. Last year, the needle was about connecting innovation to problems. This year, the needle is going to be focused on transforming the organization to be able to absorb the change, the transformation, or the innovation. And I want to be honest with you, this is much harder to pass through that eye of the needle than last year's opportunities. So let me start with something that might surprise you by defending the operating model we're about to dismantle. The traditional healthcare operating model, the one we've built over the last 50 plus years, wasn't a mistake. It was a rational response to the world it was designed for, a world where care happened inside a hospital, where the relationship was between a patient and their physician, and the system's job was to support that transition, where success meant heads in beds, managing costs, and keeping the lights on. That model worked for a long time. It worked remarkably well. It built the infrastructure that delivers care to millions of people every day. It trained generations of clinicians. It created institutions that communities depend on. The problem isn't that the model was wrong. The problem is that the world it was built for no longer exists. The patient at the center of that model, they're now consumers with smartphones, wearable devices, and an expectation of Amazon-like responsiveness. The physician at the center of that model, they're now part of a system that manages population health for thousands of patients, and they may never meet them in an exam room. The payer standing at the edge of that model, they're being asked to share risk, drive outcomes, and function as a partner, not just a claims processor. The world has changed. The operating model, for the most part, and for most organizations, has not changed fast enough. It's basically created all of these points of red on this slide. So, throughout this podcast today, I want to ask you some questions to really think about them. And here's the first one I want you to sit with for a moment. When your organization makes a major strategic decision, a new service line, a technology, a partnership, does the operating model you run it through accelerate that decision or slow it down? Be honest. Not as a leader who wants to believe in the system or the aspirational vision of those investments, but as a leader who has watched how long things actually take and what barriers we have. So let's talk about some of that challenge and some of the things that have changed in recent years. For the better part of the last 15 years, healthcare's dominant strategy wasn't transformation or innovation, it was consolidation. A merger, an acquisition, and since 2010, nearly 2,000 hospital ownership changes have occurred in the US. In the year 2000, most hospitals were independent or in small community systems. By 2025, roughly 70% of hospitals belong to health systems, and many systems have doubled or tripled in size through vertical and horizontal consolidation. Most organizations consolidated assets faster than they redesigned governance, operating models, processes, incentives, or decision-making structures. The logic was seductive, and it made intuitive sense. Bigger systems would have more negotiating leverage and more capital, more ability to absorb risk, more scale to spread fixed costs. Bigger would mean better. So health systems acquired other hospitals, physician groups, post-acute facilities, home healthcare companies, insurance plans, and more. The assets grew, the footprints expanded, and the org charts multiplied. And here is what's happened in most cases. Organizations have become larger collections of the same legacy operating model. They accumulated assets and complexity without achieving the integration, efficiency, or value that was promised. More assets plus more complexity equaled more fragmentation. not more value. So, another question. In your organization's most recent acquisition or merger, say in the last 10 years, did you redesign the operating model or did you migrate the acquired entity into your existing one? There's a meaningful difference between those two things, and most organizations, if they're honest, do the latter. Let me give you 4 specific examples of this pattern, and I want you to listen and notice how many of them may feel familiar. So, example number 1, the EHR rollout. A health system acquires 10 hospitals, 300 clinics, and 50 specialty practices. Over several years, everyone gets migrated onto the same electronic health record platform and typically the same instance of that platform. Leadership declares a milestone, and they're right, it is a significant milestone. But here's what a shared EHR platform is not. It's not a shared operating model. The clinical workflows remain fragmented, the governance structures stay local, the culture in the hospital A and the hospital B remain entirely different cultures, and incentive design probably didn't change. They share an EHR, they do not share an operating model. This is classic 2.0 thinking, and in a few moments, I'll give you a framework to think about what 2.0 means. Another example, the population health investment. Health systems invested heavily in the tools of population health. Analytics platforms, care management platforms, registries for patients, risk stratification engines, real investment, real capability. The ability to identify at-risk patients became genuinely sophisticated. But the ability to consistently act on that identification, to coordinate care across all settings, to close loops, to manage referrals, to engage patients who didn't always show up, that capability lagged significantly behind. They had insight without engagement. Knowing who needed care and reliably delivering it were 2 very different competencies. And most organizations only built the first one. So, another example, the digital front door. Organizations invested significantly in consumer facing digital infrastructure, patient portals, online scheduling, telehealth platforms, mobile applications. The entry point was modernized, access improved at the front of the patient experience. But the moment a patient stepped through that front door, phone calls, faxing, disconnected departments, manual workflows, paper, the experience behind that entry point remained largely unchanged. The front door changed, but the house behind it didn't. This is another 2.0 execution with a 3.0 facade. And finally, example number 4, today, artificial intelligence. This is the one I want you to pay the closest attention to because it's happening right now in real time in most of your organizations. Health systems are deploying ambient AI for clinical documentation, chatbots for patient interaction, co-pilots for administrative workflows. The tools are real. The capabilities are meaningful, and I'm not dismissing, but ask yourself, what has changed in your committee structures, your budget allocation processes, in your incentive design, and who has the authority to make decisions and how fast those decisions move? AI has been layered on top of unreformed operating models to make the organization faster, not necessarily smarter. And speed without structural change doesn't close the gap. In fact, it may amplify existing dysfunction. So today's health systems are the most complex organizations in the world, but the complexity was largely created through decades of mergers, acquisitions, affiliations, horizontal and vertical integration, not intentional operating model design. As organizations expanded, they accumulated the entire continuum: hospitals, physician groups, health plans, post-acute services, digital platforms, regional partnerships, layering new entities onto legacy structures built for a different era. The result is a collection of interconnected assets that often function more like a federation of businesses than a truly orchestrated enterprise. Decision making remains fragmented, data is trapped in organizational silos, governance is distributed across competing priorities, and transformation efforts are frequently pursued across functional boundaries with not much luck within the functional boundary. Healthcare has succeeded in becoming much larger, but not more coordinated. The challenge facing leaders today is not further consolidation, it's redesign, transforming a collection of acquired capabilities into an orchestrated system able to deliver seamless experience, real time intelligence, and value across the entire care ecosystem. So let's discuss the consequences of consolidation without redesign. We've already mentioned the complexity explosion and the governance gridlock. Two other things I see quite frequently is frustration across frontline clinicians. All they have is more bureaucracy, more administrative layers, and they feel removed from the ability to make meaningful decisions and improve operations. And then, of course, cost structure growth. Each acquisition adds management layers, overhead, and redundancy. And so, still, years later, 60% of our cost goes back to that workforce. We haven't made them that much more efficient or effective. So, really, the result of all of this era of this time is that we have this huge debt, that we have more complexity with added workflows, policies, technologies, and local exceptions. But what we really have is structural, cultural, and technology infrastructure that really are resistant to that change we have discussed earlier. So, what do we do about it? Well, first, let's ask you a question that will tie all four of these examples together. And I want you to think about this honestly, not aspirationally. In your organization, when a new care model gets deployed or a new technology, does it change how decisions are made, how resources are allocated, and how people are motivated? Or does it get adopted by the existing structure and run on existing rules? Because it's the latter, you're not transforming, you're optimizing. And those are very fundamentally different activities. So, why does this pattern keep repeating? Why do smart leaders, well-resourced organizations with genuine commitment to change, why do they still produce the same result? Last year, in one of our early podcasts, we introduced Martech's Law. It happens across industries, but I think it really explains why transformation in healthcare is so hard. It's pretty simple. Technology changes exponentially. Organizational changes much, much slower. Technology fast, organizations slow and resistant. And the gap between these two curves is widening over time. So in healthcare, that gap is wider than almost any other industry because we have regulatory complexity, unique reimbursement structures, workforce constraints, consensus-based cultures, and risk aversion. In fact, a client who said that if they had a vote of 99-1, it was considered a tie. All of these are working together to slow the organizational change side of this equation. And if you look at what's sitting at the bottom of that gap, you've got faxes and manual processes, legacy systems, data silos, complexity around prior authorization, staffing shortages, burnout, et cetera, et cetera, et cetera. This is not a technology problem, as we've said earlier. This is an organizational debt problem, and it's been accumulated for over 50 years. So the name of this podcast, The Eye of the Needle, sits right at the bottom of that gap. It's that narrow passage between an operating model designed for stability and volume and one that now expects you to be agile, adaptive, and move with the speed and have intelligent orchestration. And here's the hard truth. There are only two ways through. You can become more agile. You can have evolutionary change, improving your organization's ability to adapt and to be resilient, or you can reset and have revolutionary change, a fundamental redesign of how the organization operates. Both are difficult, but attempting neither is probably the most dangerous path of all. So, one more question. Which path is your organization on right now? Evolutionary or revolutionary? And well, is that a conscious strategic choice or is it what's happening by default? Often transformation feels too disruptive to do intentionally, to initiate deliberately. So, where is your organization's culture about this change? So, in the very first episode last year, I introduced this framework, the journey to high value healthcare. And if you want a much more detailed explanation, go back and listen to that. But there are four stages. Originally, when I first introduced the journey to high value healthcare over 15 years ago, there were only three. We've added the 4.0 in the last 2 years. But let's go through them quickly. 1.0 is bricks and mortar healthcare. That's where the industry started. Everything was focused on the facility. IT strategies were geared either toward the hospital or the practice. In the early 2010s, we were incented to implement electronic health records through meaningful use, and the EHR was the destination, and decision making continued to be siloed, hierarchical or command and control focused, consensus driven. ROI was rarely tracked and certainly not delivered. And this model kind of depended on the last 50 plus years. And many of the organizations I work with today still have significant 1.0 infrastructure running underneath the different stages that they've continued to build. 2.0, we've built new capabilities and systems of insight. We also rolled out clinical integration network, early value-based care contracts, analytics platforms, insight-driven decision-making, ROI and outcomes measurement were beginning to mature. And 2.0 was real progress, but what I've observed is that these are sitting on top of 1.0 infrastructure. The analytics are real. The committees running them are not that innovative. They're still driving most decisions by consensus or check the box mentality. 2.0 is also about optimization and incremental improvement of workflows, data, and technology. Many organizations today are somewhere between 2.0 and 3.0, but they're kind of stuck. And we'll get into that in more detail in a moment. 3.0 is digital health and connected care, systems of engagement, anytime, anywhere care, pay-vider convergence, population health scale, interoperability platforms, and consumer applications that actually work, collaboration across the ecosystem, impact and value management that extends beyond the four walls of the hospital. Most organizations have pilots here. Some have pockets of genuine 3.0 capability, but very few have made the 3.0 operating norm consistent across the enterprise. The gap between pilots in 3.0 and scaling in 3.0 is enormous, and it's primarily an organizational gap, not the capabilities of the technology. Smart health and care, 4.0, systems of innovation. That's person-centric whole person care, community health ecosystems, AI and machine learning embedded in care delivery, not bolted on top of it. New business models, new operating models, and new care delivery models. Disruption and creation of new value. 4.0 is not science fiction. Elements of it exist today, but achieving it at scale requires something that no technology investment can buy. It requires a fundamental redesign of how the organization thinks, decides, and operates. I am convinced we'll never get to personalized medicine, never fully realize the potential of AI, or truly innovate if we continue to embrace the operating model of yesterday. We will be covering this more in future episodes. And like I said earlier, if you want a more detailed primer, go back to episode 1 of last year. So part of what's happening is a chasm between 2.0 and 3.0 that is getting wider and wider and wider. And the gap is very, very hard to cross. And most organizations get stuck. They have outdated org structures and governance processes, siloed teams, siloed incentives, legacy processes and workflows, risk aversion and change fatigue, and they have a short-term ROI mindset. So basically, 1.0 and 2.0 were built for yesterday's world, not tomorrow's. And silos protect their territory, not the overall mission. So optimization is rewarded in 1 and 2, and transformation, which is desperately needed in 3 and 4, is viewed as risky. 3 and 4 require new trust models, new alignment, and new leadership roles. The future cannot be reached with yesterday's operating model. And in future episodes, we'll really dig into what that's going to take. So another question, and be specific. Which stage best describes where the majority of your organization actually operates today? Not your most advanced pilot, not your most capable department, but think about the entire enterprise. What is the single biggest organizational barrier, not technology barrier? What's keeping you from moving and crossing that chasm and going to the next stage? Well, I want to show you something that I show to boards and C-suites. I use quite frequently in leadership retreats. And every time we talk about this, I watch the same thing happen. People get quiet because instinctually they do realize that some of these practices are holding them back. These are the organizational constructs that still run most healthcare organizations. Not that something's wrong with every piece of this, but some of these often slow you down and frustrate the redesign and the transformation. Departments and silos where work is organized by function rather than around outcomes. Budgets and cost centers where resources are allocated by historical spend rather than future value. Committees where decisions are slowed by consensus rather than driven by insight or clarity. Consensus-based decision-making where we seek agreement instead of making the appropriate or best decision. Annual cycles where planning, budgeting, and reviews are locked into rhythms that have no relationship with how fast the market moves. And on the bottom row, static dashboards, lagging reports, looking in the rear view mirror. Incremental improvement, optimizing the existing instead of reimagining the future. Risk aversion and escalation designed to avoid uncertainty rather than capture opportunity. Hierarchy and approvals, multiple levels that slow everything down. And project and pilot mentality, treating transformation as temporary rather than progressive and future oriented. These constructs were not built for an AI world. They were not built for value-based care. They were built for a world where stability and volume rule the day. They are the number one reasons organizations struggle as they move from 2.0 to 3.0. Look at that list, and I'll go back to it in a moment. Which of these constructs would you say is most deeply embedded in your organization? Not the one you're most comfortable with, but think about the one that has the most power, because that is the one that will determine whether your AI investments and your ability to transform, deliver results, or produce another wave of well-intentioned pilots that don't scale. For the last decade, healthcare leaders have focused primarily on building and optimizing the enterprise, consolidating hospitals, integrating physician groups, and standardizing operations. That work will still be there and will still be important, but it's not enough anymore. The future will be defined by how effectively organizations connect across the entire healthcare ecosystem, creating real-time intelligence that follows the patient rather than remains trapped within an organization's boundaries. Success will depend on whole person care models that coordinate clinical, social, behavioral, and community resources around the needs of individuals and population. AI will accelerate this shift, transforming fragmented data into actionable insight and help leaders design new operating models that are more predictive, adaptive, and collaborative. The organizations that thrive will not simply have better technology, they will orchestrate information, decisions, and relationships across the ecosystem in ways that were previously impossible. I want to close this episode with the image on your screen right now because it is an honest picture of why transformation is so hard. Above the surface, what most organizations focus on, what gets the headlines, what shows up in press releases, AI, analytics, dashboards, new apps, 10% of the visible investment. Below the surface, what actually drives real transformation and change, new governance models, incentives, culture, power structures, workforce design, leadership alignment, and 90% of this invisible is not seen by the outside and almost never gets resourced. Most organizations are optimizing that visible 10% and wondering why 90% of these factors keep pushing them back or pulling them back. I've watched this play out for years. The organization that achieves real transformation, the ones that will thread the eye of the needle, are not the ones with the best technology. They're the ones that have the courage and the discipline to redesign what's below the surface while deploying what's above it. That is real work. It's really heavy lifting, and it's part of what's exciting, but also part of the challenge. One final question, and I want you to really sit with this. Is your organization's transformation agenda primarily focused on what's above the surface or below it? And do your board, your C-suite, and your operational leaders share a common understanding of what's below the surface and what transformation is going to actually require? If this episode resonated, if the questions I've asked today surface something you've been sensing but haven't had the language for, I'd encourage you to do two things. First, share this episode with someone in your organization who needs to hear it. A board member, a fellow executive, a clinical leader who is doing everything right at the point of care and still hitting these walls we've discussed. The conversation that follows might be more valuable than the episode itself. Second, hit subscribe if you're a leader who recognizes your organization and what we discussed today, and join us for future episodes. If you want to have a real conversation about where you are on this journey and what it would take to move, reach out to me directly. My contact is on your screen right now. Been doing this for a long time, and I know what works and I know what doesn't, and I know how to help organizations stop optimizing that visible 10% and start doing the harder, more important work below the surface. So thank you for being here for season 2 of The Eye of the Needle. There's a lot ahead this season, and we're going to go deep on each stage of the journey. We're going to talk about what leadership actually looks like in 3.0 and 4.0 world, and we're going to bring in voices that will challenge your thinking and expand you to believe in the possibility of the future. The needle is narrow, but it can be threaded. I've seen it done, and I know what it takes. I'll see you next time.